Awesome. All right, hello everyone. My name is Eric Wu. I am one of the emergency medicine doctors. I was asked to come and chat with you all about scene safety in the era of COVID and other infectious diseases. So, my disclosures, I'm one of the UC Health Memorial ER physicians. I also work at Denver Health as an ER physician. I did my EMS training at Denver Health after residency. Currently, I'm a medical director for Sherman Hills, Broadmoor, ambulance in the southern region, as well as a company up in Denver, Colorado, Cardiac CPR. So other than that, I don't have any other financial disclosures. So the overview today simply is this. We're going to talk about how COVID has changed our approach to scene safety. We're going to discuss some of the current recommendations in terms of precautions that we should be taking, and then we will move forward about the future and what that might look like moving forward if and when COVID is over. So obviously, everybody just experienced 2020, and COVID had a pretty significant impact on all of us. We're not here to talk about the virus itself, okay? This is not a virology course. This is not a discussion that's going into the minute mechanisms of how the virus infects the cells. Instead, we're looking at the bigger picture of how it impacts us when we're coming onto the scene. So very, very briefly, we know that COVID is the disease syndrome that is caused by the SARS-CoV-2 virus. Now, this is a viral respiratory illness which can kill people, and even if it doesn't kill people, can actually leave permanent or at least semi-permanent damage, as we're discovering. It has really changed how we respond to calls. The one quote I want to say and have you keep in mind is that there is no emergency in a pandemic. And what does that mean? It means that if you don't take care of yourself first before you walk into a room or into a patient's home and you end up catching something and getting sick and you go down, there may not be anybody else in the system to take your place. And especially as a pre-hospital provider, you are an important link for our patients and their health and their care. And I just wanted to dispel the myth that you should be rushing into patients' rooms without any gloves or gowns or masks, because again, when we're dealing with the pandemic, we have to be mindful about what we're doing and how we're exposing ourselves and trying to limit that risk. Now, when it comes to infectious disease and spread, there's a classic model that we use, and we distinguish for these respiratory illnesses between droplet and airborne. Now, droplet, typically speaking, we're talking about particles that are larger, and the cutoff that we generally use is 5 microns in diameter. Now, what does that actually mean? Well, if you imagine if you have, say, a water droplet and you fling it into the air, because of how big it is, it generally doesn't go too far, and it will generally fall and hit the floor and won't hang around in the air for a long time. So that's what we mean by droplet spread. Now contrast that with airborne. With airborne, we're talking about particles that are less than 5 microns in diameter. And in these particular cases, these tiny, tiny little particles can actually float in the air for an extended period of time. And by virtue of its size, it also has the potential to spread further. So that's the classic paradigm in terms of how we think of respiratory illnesses. So the question then comes down to, and this is a nice little diagram here that shows you kind of what we talk about when we talk about droplets versus airborne. And again, whenever we breathe, cough, sneeze, talk, all those things, we're generating particles, okay? So the question then is, how is COVID actually spread? Well, to be perfectly honest, we don't truly know. The likelihood is that most of the spread is actually done via droplets. And what I mean by that is in most settings where, like, if you visit a friend out of state, or if an out of state friend comes and visits you and they have COVID, and you and them are just talking and you're spending like 3 hours with them in close proximity, it's probably droplets from that infected individual that's then coming on to you. And it's less likely that it's truly airborne. But, and this is the big but, in pre-hospital medicine with EMS or emergency medicine, we do aerosol generating procedures, okay? So these AGPs. And what do I mean by that? I mean chest compressions, ventilation, whether that's CPAP, bag valve mask, supraglottic airways with eye gels, etc. All of those procedures, as we're doing those procedures, it generates particles that are much finer than what I'm expelling right now. All right. So then what that means then is that there's a much higher likelihood that these particles are actually becoming airborne rather than just droplet. All right. So keep that in mind. So is it really just that simple? Droplet versus airborne? Well, yes and no. All right. Keep in mind that there's also a time component to infectious disease. If you think about it, if you are spending, again, think about your friend that's visiting from out of town, okay? And you're spending 5 hours with them in a room versus 5 minutes in a room with them. Which scenario do you think is going to increase your likelihood of infection? What's going to be the scenario where you're spending 5 hours with that person, right? And so there's a time component to whether or not you or your loved ones or whomever may end up getting infected. In addition, the ventilation of the room, the airflow of the room, that can play a huge component into how these infections are spread. The other thing too is that each individual virus or infection, they all require different amounts of bacteria or viruses to actually trigger that infection. So those are all dynamics at play that we can't necessarily put into like a simple calculator and tell you what your risk is. But what we do know is that all of these are factors that play into it. All right. So I know you all came here to listen to a talk about scene safety, right? And probably none of you expected that we would be playing a little math game today. So let's just bear with me here. Let's go through this exercise, and hopefully this illustrates some of the importance of general infectious disease precautions that we want to take, and it just highlights, again, these principles, all right? So if you imagine, I've got a person who's infected with COVID or, I don't know, flu or whatever virus. It doesn't really matter, okay? But as they're breathing, each minute that they breathe, they're actually expelling out 100 viral particles, all right? Now, every 2 feet that it travels, those viral particles that are still in the air, it drops down by half, okay? So if you imagine at 2 feet, I might still have 50 particles in the air. And at 4 feet, 25. 6 feet, 12 and a half, so on, so on, so on, okay? So this is the scenario that we're painting, all right? Now you, as an uninfected individual, are standing 4 feet away from this infected person. And let's imagine that if you happen to wear an N95 mask, that it's going to decrease the amount of viral particles that you effectively see, right? It's going to decrease it by about 95%. So you only see 5% of the particles that are hitting your face, okay? In terms of like your nose and mouth. Now, in order to actually get an infection, a clinically significant infection, you need to end up getting exposed to 100 viral particles, all right? So the first question I'm going to ask is, how long can you stand there if you have an N95 on until you get sick? All right, so that's question number one. And then question number two is, well, let's take away that mask. How long can you stand there? All right. So I've been told that there's a way to pause this presentation. So I'm going to give that opportunity for somebody to pause it. I'm going to let you guys try to work this problem out, and then we're going to see if we get the same numbers. All right. Okay. So hopefully the presenter was able to pause and I don't look foolish just jumping right in. So let's talk about the first question. Again, remember, infected person right here, they're expelling 100 viral particles per minute, okay? And you're standing 4 feet away from the person and you've got a mask on. So at 0 feet, if you were kissing that person, you'd see 100 viruses per minute. And at 2 feet, again, every 2 feet, we have that number. You're at about 50 viral particles per minute. And at 4 feet, you're about 25 viral particles per minute. Okay? Now, you happen to have an N95 on, right? And the N95 can filter out 95% of the crap that it sees. So it's only letting through 5% of the stuff. So how much of the stuff are you actually getting? So you take 5%, you multiply that by this number, right? Because you're at 4 feet. So you're getting about 1.25 viral particles per minute. All right, so remember, for you to develop a clinical infection, you need 100 viral particles. So how do we get that number then in terms of minutes? Simple. Take 100 viruses, divide by 1.25. So effectively, with an N95 on, you can stand there at 4 feet for about 80 minutes. All right? So that's the number I got, and hopefully you got that number too. So then let's go on to question number 2. Well, what happens if you stand there without a mask? So you have no filter, right? You don't have this filter anymore. What happens? Well, 100 viruses per minute at 0 feet. At 4 feet, 25 viruses per minute. No mask on. You need 100 viral particles to get infected, so you take 100 and you divide by 25 viruses per minute. It's about 4 minutes, all right? Now, these numbers are hypothetical, all right? These numbers are simply an example to illustrate how time, distance, and the presence or absence of a mask can impact viral transmission or infectious disease transmission. All right? This is truly multifactorial. There is no way for me to predict, if you gave me a scenario, whether or not you are going to come down with an infection. There's just no way. We don't have the calculators for that. We don't have the science for that. Not at this time. However, what we do know is that we can control certain factors, and there's certain factors that we can't control. All right? So let's say, again, I've got my friend from out of town who's visiting. Maybe I don't give them a hug or a kiss or whatever. Depends on what kind of friend. But maybe I'm not getting super close to them. So I'm able to control that distance factor. Okay? Maybe from a time factor, maybe we're spending, maybe they're just driving through town. Hey, let's go grab a coffee, just catch up 15 minutes or so. Versus, let's go to a crowded bar, let's go hang out there for several hours, etc. Okay, that's a time factor. Ventilation, being outdoors versus being in a confined closet. All right? So that plays a role. So that's in the general community. Now let's talk about EMS. When you're responding to a call, do you really get to control the scene? Sometimes you do, right? Sometimes, not always. But oftentimes when you're walking into a patient home, are you able to control that ventilation? Maybe. That's a possibility. What about distance? Well, let's say the patient is pulseless. Are you able to do compressions from a distance? I don't think so, right? How about time? Let's say this is the patient that you're going to be in the back of the ambulance for 30 minutes. How are you going to be able to control that time? So oftentimes, these are factors that we will try to control, but we can't necessarily control, right? So of the things that we discussed, well, what can we actually control? Well, masking, we can control. Whether or not the patient has a mask on, or if I have a mask on, right? I can control that. So why wouldn't I choose to control that? 2020 has been a challenging year. Politics notwithstanding, the virus doesn't care how you vote. The virus doesn't care about whether or not you wear a mask, because it will infect whatever it can if it has the opportunity. However, if you do wear a mask, you decrease that likelihood that the virus will actually infect you. So the question is simply, do masks work? Yes, they do. This is not up for debate. It just isn't. This is the one thing that you can control. to keep yourself safe and your loved ones safe, all right? There is such a thing as asymptomatic carriers. I am tired of hearing, oh, well, I feel fine. Well, so what if you feel fine? If you are actively shedding viral particles and you give it to your spouse, your parents, your patients, and they die, ask yourself, is that something you're okay with? And if so, if you're truly okay with it, think about why is it that you don't have that empathy for them, right? Because this is a real disease. If we really still want to have this debate in the year 2021, my proposal then is, I'm sure you won't mind the next time that I put a central line on you, or on a loved one that I choose not to wear a mask or gloves. Okay? If we're truly going to have this debate, I'm sure you won't mind then if I don't wear gloves or wear a mask. I promise you, I'll wash my hands. I promise you, I'll try not to breathe too hard on the line or to sneeze at the line. But think about how ridiculous that sounds. Better yet, go ahead and ask your surgeon the next time that they're going to operate on you or your loved one to not wear gloves or a mask. Go ahead and ask them that. See how they feel about it. All right? This gentleman in the bottom right here, who's shedding a tear, all right? His name is Ignaz Semmelweis. All right, now he was a physician. Newsflash, he's the father of modern hand washing, okay? This guy discovered, or rather demonstrated, that you should not perform dissections on cadavers in the morning and then go and deliver kids in the OB ward without washing your hands in between. Because guess what? When you have your hands in dead people and then you go and deliver a kid and you don't wash your hands in between, those mothers tend to die of bad infections. So it took this gentleman, discovering that, hey, we should probably wash our hands in between seeing patients, or if we're doing something unsanitary, to prevent infection spread. All right? He ended up actually getting laughed at by his peers, which is the sad part. Okay? This is the sad part, is that he was absolutely right, but the medical community at that time thought he was crazy. All right? Don't make him sad. Please, please understand infectious disease is something that we have been dealing with for centuries, right? And there are steps that we can take to reduce the spread and to reduce disease burden. All right? So don't make Semmelweis sad. So what are the current recommendations? Well, we would recommend that masks be worn for every patient contact. Now again, why is that? We know there is such a thing as asymptomatic carriers. So it could be that ankle sprain or that broken arm that you're responding to. Although they don't have a cough, they don't have a fever, they don't have shortness of breath, there is a small possibility that they could be asymptomatic. So why not take the small extra step of just putting on a surgical mask and going in to treat the patient? All right? So for most patients that we're going to run on, a surgical mask is probably fine. Now, if the patient has a respiratory complaint or fever, and again, sometimes in 10% of patients, vomiting and diarrhea are the presenting complaints for COVID patients. So sometimes with GI symptoms, you ought to wear an N95. All right? Again, when we talk about mask efficacy, right, we really can't control the time, can't control the distance. We have some control over the ventilation. But the masking, the N95 has much better filtration than just a simple surgical mask. So decrease the likelihood that you're going to get sick and wear the N95. Now, if you know you're going to a cardiac arrest, or you know that you're about to start CPAP on a patient, again, these are aerosol generating procedures. So you should wear an N95 in these cases. Again, decrease the likelihood. This is all about chance and risk mitigation. All right? So do the right thing and decrease your risk. Now, the issue with any viral infection is that there's also a chance that it can get spread through the eyes, okay? In the sense that the eyes are a mucous membrane that's exposed in the environment. If somebody sneezes on me, and even if I have a mask on and I'm not breathing, and that sneeze hits my eyes, there's a chance that I can still get an infection. So we would recommend just simple, like little goggles, all right? Those little plastic flimsy goggles. It's all right, you know, but I'd recommend it for every patient contact. That's what we're doing in the emergency department, all right? We have eye protection for every single patient contact. Now gloves, hopefully nobody's still going out there without wearing gloves, you know? It's just, I know old school, you know, I've seen pictures where you've got like the Denver Health paramedics, their hands are just full of blood because they've just barehanded trying to like stop a bleeding chest wound or abdominal wound, and they're just applying pressure with their bare hands. No, we don't do that anymore. Okay? So please wear gloves. All right? Simple as that. Gowns, if you know that this patient is positive COVID or if they're having respiratory symptoms, we strongly recommend it. And whenever possible, if you can maximize the ventilation, especially in the back, try to do so, right? Try to do so. So that's the current recommendations and their precautions. So the question on everybody's mind, hopefully, is, well, what does the future hold? Well, it really all depends. It really just depends on how we choose to respond today. Okay? And what are some of the factors that play into this? Well, rates of vaccination, what the patient's chief complaint is moving forward in the future, and the bigger question is, are we going to be in another pandemic? So what does this mean? So let's talk about the vaccine. If we can get enough people vaccinated, then we will get this effect of herd immunity, okay? Now, this word has been thrown around a lot, you know, whether good or bad, all right? Herd immunity, the concept is that if enough people have been infected or are immunized by vaccines, then the disease stops in its tracks and it doesn't continue to spread and eventually will die out. All right. I don't think this is going to happen. And this is my pessimistic, realistic self when asked this question. Do I think herd immunity is going to happen for COVID? No, I do not. Why? Well, just ask your Facebook friends why. All right? This is another reason why Facebook is not exactly the most trusted news source for medical information. The amount of hoaxes that are being, you know, spread about Microsoft and Bill Gates or 5G internet causing COVID spread, et cetera, et cetera, et cetera. It's mind-boggling, unfortunately, how many people believe in these things, all right? And there is enough distrust, unfortunately, in the medical community, or at least directed at medical providers, that there are people who are smart people, but they are choosing not to get the vaccine. The chances are that as we're having this presentation, that some of you in the audience, or people that you know who are close to you, whether it's, you know, family members, close friends, there are some of you that probably won't choose to get the vaccine for whatever reason, okay? And as a result, we will never achieve herd immunity. Why is that? Well, we need to get 70 to 75% at least of those people in the world to have had the infection or to have had the vaccine at a certain time point, all right? The reality is that COVID infections, as you get the infection, you have initially natural immunity, but this natural immunity will wane, meaning it will disappear. The exact time frame for when it disappears is not entirely clear. It's thought to be somewhere on the order of months, okay? There was a study looking at the amount of antibodies present, and at about 8 months or so, only 54% of patients who had confirmed COVID cases still had antibodies. All right? So natural immunity wanes. So what does that mean? Well, it means that this patient, which was formerly immune, is now vulnerable again. And when you have a vulnerable patient, they're no longer in that 70 to 75% of the herd. They've now fallen out of the herd, so your herd decreases. All right? And so this person then has the chance of getting infected again and spreading the virus again. All right? And so if we never get enough people vaccinated / infected, which that's another conversation to have, well, we won't get that herd immunity. Now, again, best estimates, natural infection, somewhere in the 6 to 8 month range, probably. Maybe in some cases, patients can have natural immunity up to about a year. Whereas with vaccines, we are estimating, again, estimate, at least 1 to 2 years. When we look at the antibody titers after getting the second dose, it is multiple folds higher than if you were to just have had a natural infection. Okay. So, some people like this idea of, well, let's just let the infection run its course and get COVID parties, and that's how we're going to get herd immunity, et cetera, et cetera, et cetera. Let's talk math again, because at the end of the day, numbers don't lie, right? 1 + 1 equals 2, right? 2 + 2 equals 4, right? And if you live in an alternate world, maybe in a flat world, 1 + 2 might equal 7. I don't know, I'm just saying that numbers generally don't lie. This is a popular Facebook post that unfortunately I see. We hear that the vaccine is 95% effective, okay? And so your aunt and uncle or your brother or your sister on Facebook, well, I'll take the 99% survival over the 95% effectiveness over, any day of the week. They're confident when they say it. They say it in all caps, they bold it, they underline it, whatever. Well, I'm going to tell you right now that they're wrong. Just flat wrong. This is not how the math works. Okay, you're comparing apples and oranges. Effectiveness is not mortality or survival. That's not what effectiveness means. So let's actually look at the numbers, okay? Let's actually look at the numbers here. COVID mortality, best that we've observed, somewhere on the 1 to 2% range. So let's just use 1.4%, okay? That's some of the studies are somewhere around there. You might think to yourself, well, what's the big deal with 1.4%? Well, the vaccine mortality rate is 0%. All right. Which one's bigger? It's not a hard math problem, right? Is 1.4 or 0 bigger? Well, 1.4% is bigger. So which scenario, if you got the vaccine or if you got the infection, which scenario is it more likely for you to die? Well, it's the scenario where you get the infection, the 1.4%, okay, compared to 0%. So in the trials, they vaccinated about 70,000 people. Okay, these were the clinical trials that they were doing, and they had 0 deaths. If you had infected them with COVID instead, you would have killed 980 people. So when people want to talk about having COVID parties and having herd immunity, brought about that way, well, let me tell you what, if you find somebody who tells me that they would rather take a 1.4% mortality risk over 0% mortality, send them my way. I've got a great investment plan. I will happily be their investor for them. I will happily manage their finances because clearly they don't understand numbers. All right? They clearly don't understand numbers. Moving on from vaccines. Well, what is the patient's chief complaint? In the future, it's certainly a possibility that some agencies may mandate that providers wear masks for any patients that they come across with respiratory illnesses, even outside of pandemic times. And why is that? Well, when providers go down with respiratory illnesses, it creates a huge burden on the workforce. We saw drastic examples of this in New York, right? When 20–30% of their workforce went out. Now imagine, okay, that's New York City, right? Big city, hundreds, thousands of providers. Let's imagine you're in a small town and you have 10 providers, all right? And 3 of them go out, or 4 of them go out because of the seasonal flu, right? They all responded to one respiratory distress patient, all right? It's not a pandemic, okay? We're not talking pandemic. But the patient has really bad flu. They were struggling to breathe. You all threw CPAP on the patient appropriately. It helped the patient, all right? But you've got 3 or 4 providers in the back of that ambulance not wearing masks, breathing the same air, the same droplets that this patient is expelling. Now three of the providers end up coming down sick with the flu and a bad case of it. How is that going to impact your staffing? How is that going to impact your ability to respond, or how many units or assets that you have out there, right? So these are the realities that we have to face. Here in the United States, we have been very lax about infection prevention. That's just the reality of it. When you look at other countries who have had experiences with respiratory diseases, the initial SARS outbreak, you'll see that providers tend to wear masks on patients most of the time. So this experience may, and I'm not saying it will, but this may potentially have some agencies choosing to ask our providers to wear masks. And if they do so, I think it's with very good reason. I think that we have proven that we are unable to look after ourselves and that we continually are behind the 8 ball. So the only way to stay in front of that 8 ball is if we're proactive about it and decreasing our exposure. And then finally, well, what is the future pandemic going to be? Mark my words, there is going to be a future pandemic. It's just a matter of time. Back in 2015, we were already talking about the next big pandemic, and guess what? It happened in 2019, 2020. So these pandemics happen. Now, it's estimated the annual risk of it is about 1%, right? So 1 every 100 years. It doesn't mean that we start the clock and wait 100 years from the next pandemic. No, it just means that every year there's a 1% chance, right? So there is likely going to be another pandemic in the future. We just don't know when it's going to be. We don't know what it's going to be. It could be another coronavirus like COVID, or it could be influenza, Ebola, anything. We need to be able to adapt to whatever that new pandemic is, all right? Meaning we need to stockpile enough equipment, PPE. We ran into these troubles in 2020. This should be a wake-up call to say, hey, we need to make sure that we've got our stockpiles and that they're adequate, and that if we do find ourselves in a pandemic again, do we have the supply chains up and running? Do we have predefined flow for how these supplies are going to get to us? How are we going to purchase them, et cetera, et cetera? All right. I hope, fingers crossed, that we've learned some lessons. All right. I hope. All right. But we'll see. Now, you'll see I noticed, you might note, hey, the 1918 Kansas flu, why are you calling it the Kansas flu? I thought it was the Spanish flu. Well, it actually turns out that the first documented cases actually came out of Kansas in 1918. And then it was from Kansas that it then spread to the rest of the world. So we actually have the proud origination story from the US. All right, the US was actually the origination of the 1918 pandemic flu. All right, so just a little fun footnote in history. We really don't know what it will be in the future, right? It could be a bloodborne viral hemorrhagic fever like Ebola. All right, and so again, that's when your contact precautions are going to be especially important, but you're also going to need to get the splash protection, right? And all of those things. We just don't know what the future pandemics will be. So we need to be ready. All right. So, in summary, do your part, wear your PPE, follow the guidelines, and keep yourself and your loved ones safe. If you're able to, please, 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 please get the vaccine. Okay? I got my vaccine. My first dose was in mid-December, and my second dose was on January 6th, 2021. All right? As far as I know, Bill Gates can hear my thoughts. Yeah, I don't care. You know, guess what? He doesn't care either. All right? I am grateful that I got the vaccine. I am grateful that I have developed an immune response to it. I feel more comfortable going around in the world. I hope that we can get herd immunity. All right? I want to be proven wrong. All right? I want to be proven wrong. But please get the vaccine. And finally, there's a fun phrase that I think most of y'all will have heard at this point. Play stupid games, win stupid prizes. So what's the bottom line? Don't play stupid games, all right? Do what you can to keep yourself safe. These are pictures from the 1918 Kansas flu, all right? And you'll see back then that they were talking about wearing masks. This is not a new concept. So please, please, please do your part. Try to decrease the spread. Keep yourself safe. And hopefully we can get through this. All right, that's all I've got.
You go up to the red dot.